60-year-old morbidly obese woman with a history of oxygen-dependent COPD and substance abuse presents to your hospital after sustaining a hip fracture during a fall. She takes 90 milligrams of methadone daily. While in the emergency department, she receives 100 micrograms of fentanyl, 4 milligrams of hydromorphone, and 90 milligrams of methadone. Her pain is poorly controlled despite these medications. The team is concerned that she is at risk for respiratory depression and orders continuous pulse oximetry. At 3 a.m., she is found to be hypoxic to 75% with agonal respirations and no palpable pulse. CPR is started and she is given 2 milligrams intravenous dose of naloxone. She awakens, is shivering uncontrollably and crying in pain. What happened? Opioid analgesics are administered to more than 50% of non-surgical inpatients. While opioids are effective in providing analgesia, adverse events are common and may include life-threatening CNS and respiratory depression. Identification of high-risk patients is essential prior to opioid administration. Consider the following 5 assessments when starting inpatient opioids. First, we must first screen patients for features that predict a high risk of respiratory depression when initiating opioids. Age plays an important role. Elderly patients are at a higher risk of opioid overdose than their younger adult counterparts. That risk is 2.8 times higher for individuals aged 61 to 70, 5.4 times higher for those aged 71 to 80, and 8.7 times higher for those over the age of 80. Pediatric patients are also at an increased risk of overdose and should be receiving doses appropriate for their age, weight, and tolerance. Sleep-disordered breathing includes both obstructive sleep apnea and central apnea. Sleep-disordered breathing is worsened by opioid-associated sedation due to the blunting of the normal response to hypercarbia. Patients with known obstructive sleep apnea are clearly at risk for advancing sedation and respiratory depression when given opioids. However, many patients will have undiagnosed sleep-disordered breathing at time of their hospitalization. Predictors of obstructive sleep apnea include the male gender, obesity, a BMI greater than 30, snoring, witness episodes of apnea, excessive daytime sleepiness, and hypertension. Anatomic derangements that impair breathing, thoracic or abdominal injuries, incisions, or kyphosis also increase the risk of respiratory depression. And patients with underlying pulmonary or cardiac disease, particularly those requiring baseline oxygen, are also at risk. Remember that patients with end-stage liver or renal damage require dosage adjustments of their opioids. These dose adjustments are listed in the package insert for each individual agent. Second, we need to understand the patient's baseline level of tolerance. Patients who are habitual opioid users and require high doses of opioids are also at an increased risk of respiratory depression. Rapid dose escalations must be avoided in these opioid-tolerant patients. On the opposite end of the spectrum, patients who have not used opioids at all in the recent past may also be more likely to be more sensitive to the opioid's effects. And patients who finally achieve pain control after a long period of uncontrolled pain are at a risk of opioid-induced sedation or respiratory depression. Is the patient receiving other sedating medications? Have they ever had respiratory depression requiring naloxone in the past? If so, they are also at an increased risk of oversedation. Third, we need to exclude any other opioid exposures, ensuring that the patient does not have things such as a fentanyl patch, implanted pump, or home opioids with them. Fourth, we'll focus on a multimodal, individualized analgesic plan for each patient that includes non-opioid medications and adjuvant therapies. Combining opioid medications with other sedating medications such as benzodiazepines, antihistamines, barbiturates, or other central nervous system depressants can cause oversedation and respiratory failure. Fifth, high-risk patients receiving opioids require thoughtful monitoring strategies so that respiratory depression or sedation can be identified as early as possible. Specific monitoring techniques will be addressed elsewhere. Share this video with your team and help make sure that everyone is able to recognize which patients are at a risk of iatrogenic opioid overdose.